Thank you for that warm welcome, and thank you particularly for the invitation to contribute today. Firstly, I'd like to acknowledge the Wurundjeri, as has already been done. My mother's family is from the Western Districts of Victoria, Gunditjmara country. I grew up, I usually say I grew up when I left Adelaide, and I've been in Melbourne for the last 12 years at the University of Melbourne. I was welcomed, have been welcomed onto country numerous times, particularly by Auntie Joy and Auntie Di, and we had the great pleasure a few weeks ago when we launched the Melbourne Poche Centre, which I'll tell you a little bit about, 2 weeks ago, when she gave a very generous welcome to country and talked of her hopes for particularly Victorian Aboriginal kids and their health. Partly because what I'm going to talk about relates to my doctoral research actually, and the building works remind me that I did my doctoral research in Christchurch either side of the big earthquakes. I got there a week after the first and left a week before the second, but in that 6 months this kind of feeling went on and on and on. As I said, thank you for your welcome, Tony, and acknowledge your role and acknowledge Bishop and Mrs. Newell. I met Christopher once. He came to Melbourne as a guest, or as a colleague I would say, of Professor, or soon to be Professor Lynn Gillum, another bioethicist, as we were doing some work, and I remember him as, whether he was having a good day or not, as engaging and forthright. So, I'm going to talk a bit about this notion of unequal treatment and reconciliation action plans in a health context. And as has already been pointed out, I hold the role still of the Associate Dean for Indigenous Development in the Faculty of Medicine, Dentistry and Health Sciences at the University of Melbourne. And the reason I say this is it was the first position of its kind in the country, and it was created explicitly for our faculty to ensure that we did what we needed to do in and around Indigenous development. The position sits on the faculty executive with the other senior roles, and we've found that it's been critical to, if you like, be in the room where the decisions are made, and to ensure that all the decisions that we make in the faculty take into account Indigenous development, and I'll talk a little bit more about that as we go on. Just very briefly, the Poche Centre, and the reason I'm going to describe what we do is because when we come back to it, I think it's an example of what can be done and what Indigenous development can attract in some senses. We at Melbourne were the recipients of a $10 million gift from Greg and Kay Poche in May of this year. I was in Sydney on Friday where they gifted another $10 million to the University of Queensland to establish another Poche Centre for Indigenous Health, which takes to 5 Poche centres around the country, all at universities, Sydney, Flinders, Western Australia, Melbourne, and now University of Queensland. Over and above that, they've gifted 40 or 50 million more dollars for the melanoma centre at RPAs in Sydney. I think one of the things that enabled us to be in a position to receive the gift, not me personally, but the institution, of developing the role of Associate Dean, so that we'd done a whole range of things that ensured that we could seriously look them in the eye when they said, would you like $10 million? And we could develop a proposal that they could feel very comfortable about. So it's a new centre. We have a vision for 20 new Aboriginal PhD students to be enrolled in the next 5 years, as well as establishing a parallel leadership development program. But again, you'll hopefully get why I've mentioned that when we get to the end of the discussion. I probably won't talk for 45 minutes, but I hope that then will allow us some time for some questions and comments from you, if that's appropriate. This is a picture of that's in the State Library of Victoria of the burning down of the first Melbourne jail. I know at least several of you flew in from Canberra. I expect all of you that flew in came in through Tullamarine rather than Essendon or Avalon. But Tullamarine, before it was a suburb, was actually the name of an Aboriginal man, Tullamarina, and he was jailed in, I think, 1875, and he decided to burn down the jail so that he could escape. Again, the story will make sense as we go along, but he was jailed for stealing someone's potatoes because his family was hungry. And John Gardner, who had settled in the north of Melbourne, was growing his potatoes on someone else's land. And to Tullamarina, the spread of the settlers seemed incessant. He just simply wanted to feed his family. So it's a story of a settler and a local, and it's a shared story. And when we talk over the next 20 or 30 minutes about reconciliation action plans and unequal treatment in health, it's a story that makes little sense without hearing, I think, both sides. I'm sure you're all absolutely aware of the health gap between Aboriginal and non-Aboriginal Australians, and I'm not going to go through those statistics for you, many of you I'm sure for the 100th time, but to note that it's true for most settler colonial nations as well. What I do want to talk a little bit about is this disparity in healthcare outcomes, that not everyone who presents at a clinic with the same health condition gets the same health care, nor are their outcomes the same. And there was a seminal book, or collection of articles really, research published in 2002 in the United States, which basically said that racial and ethnic minorities tend to receive a lower quality of health care than non-minorities. And I'll get to this word of minorities shortly, but even when you took into account a whole bunch of other factors. And the sources of these disparities are complex, but they include the actions and behaviours of healthcare professionals. And most of this research has been carried out in the United States and Canada, and we're actually just starting to do some of our own research. And a group of working with me have very recently, although unpublished at the moment, decided we'd see what it is like for Australia in terms of some of our medical students, fourth-year medical students. And so we wrote up a case, and the case was a 40-something-year-old woman whose husband was in the military, and she travelled around a bit, and she turned up to see a GP for her sore foot and her out-of-control diabetes. For half the cases, we described her as a 40-something-year-old woman, and for the other half of the cases, we described her as a 40-year-old something Aboriginal woman. And the title of our yet-to-be-accepted and published article is Subtle but Persistent. The responses, the difference between the responses of the Aboriginal and the non-Aboriginal case, one word, were subtle, but they were persistent. And whilst there's some limitations in case-based scenarios like that, it did show that for Australian students, and we did a small cohort in Hawaii as well, there were still differences in the way that the patient was perceived. Now, that could actually be read two ways. One is bad and one is good. In fact, we don't want everyone treated the same. We want everyone treated according to their need. And so we're not yet sure that these are just stereotypes coming into play here. But we are aware that there are still some differences in an Australian context, and we need to unpack that a little bit more. We also know that these things happen not just, whilst I'll talk a little bit about Aboriginal health, we know that these things happen across a whole range of other areas, including disability, including gender, including age, including sexuality, to name just a few. So I've got just 3 slides around health spending and the pharmaceutical benefits scheme. They are now getting slightly old. They're from the 2007 Australian Medical Association report card, although the data is now from 2001. But some of this hasn't changed significantly. And basically what it shows, in particular on this one, if you look at the very last bar chart that is the total, despite Aboriginal people having 3 to 5 times the mortality rate, the overall expenditure is only a small fraction of the comparative expenditure for non-Aboriginal people. So in fact, this notion of treating people the same, or actually treating people according to need in terms of spending, isn't yet borne out. More starkly, I think, is the pharmaceutical benefits scheme, which is poorly accessed by Aboriginal people, regardless of whether they live in the remote, regional or cities, compared to non-Aboriginal people, that the PBS is much more highly utilised by non-Aboriginal people. And finally, a example of differential ways of treating, and there's a whole range of reasons that might contribute to this as well, but this shows that the proportion of coronary heart disease hospitalisations, that non-Aboriginal people generally received more interventions than Aboriginal people. Now, we did a repeat, or not exactly a repeat, but we looked at some data at St V's, just the other side of town, St Vincent's, a couple of years ago, and the first cut of this, we need to be careful of data is what I'm about to say. The first cut of data showed us that we thought Aboriginal people were given different treatment at St Vincent's if they presented with a heart condition. But when we burrowed down a bit further, we realised in fact the difference wasn't Aboriginal or non-Aboriginal, the difference was private insurance versus public insurance. And then once you took that into account, in fact the treatment was very, very much the same. So we need to be careful about how we overlay identities on data. But how do we make sense of these previous slides and what might it have to do with what we want to talk about? Christopher actually said, indeed of our experience being other, our experience of being other needs to be seen in terms of oppression. Fairly straightforward and blunt. But it's a really nice way to think about it because, as I said, I wanted to talk about this notion of minoritized rather than a minority. And minoritized groups, if you think about this process of being minoritized, it's a social process. It's made up of individual acts, and it's different from just being a numerical minority. Aboriginal people are a numerical minority, but over and above that, I think we could argue that there's social and political processes that minoritise Aboriginal people. And picking up some of Christopher's previous quote, we could talk about it as being a social act of oppression, and you can make these analogies and parallels in a whole range of other minoritised or minority groups for yourself. And so this notion of cultural competence has emerged over the last, since the Unequal treatment paper really in 2002, and before that, but response to a growing understanding of unequal treatment has been the growth of cultural competence initiatives in the health sciences, much of which means that in medicine, dentistry, nursing, social work, physio and so on, that we try and teach the students this notion of cultural competence through a whole range of different and often contested ways. Unfortunately, at the moment, my view on cultural competence is it probably makes the lecturer feel better than it does much for the patient downstream. We all feel good to teach Aboriginal health and history or the notions of cultural competence in a whole range of ways, but there's actually no evidence yet to say that necessarily impacts on patient outcomes as a student graduates into a practitioner and so on. And I think another way to think about cultural competence might be to take it back a step or two and try and think through some more values-based approaches to health and healthcare. In terms of Aboriginal health, every medical school, every faculty of health sciences across the country will do this differently, and appropriately differently in terms of talking about local people. We acknowledge Wurundjeri, and it would be inappropriate to acknowledge another group in the country in terms of acknowledgement of country. But in terms of cultural competence, which culture do we actually want to start to learn about, and how does that translate to a whole bunch of other cultural groups? And as I mentioned before, not just in a racial or ethnic sense either, but in the whole other social cultures that we have, that we would ask doctors and other health professionals to think outside of their own lived experience into someone else, and understand someone else's lived experience as they present to them. So that's where cultural competence has been going. That's the kind of first definition of it in 1989, which starts to talk about a system, agency amongst health professionals, and to ensure professionals can work in cross-cultural situations. I think in its intent, it's probably a very good idea. And talking a bit more about reconciliation action plans, I wonder if, as we get into reconciliation action plans, they might in fact be an act of cultural competence in terms of thinking through what they might do for an institution, an organisation, and for the individuals within that. So I'm going to give you a little bit of background and use medicine and medical schools as an example of change, of what's possible, against perhaps a backdrop of unequal treatment, as we've talked about here, and certainly the interests of health consumers as well. This is I promise you, I think this is my last graph. This is from Medical Dean's data collection, and it shows, the blue line up the top shows the increase mostly of Aboriginal Australian medical students from about 2003. So I think we've got 18 in 2003 with a dip down to about 12 or 13 in 2004 and up to more than 80 in 2014. So a really wonderful increase in participation in the health, or access, and also participation in the health workforce. What's lagging a little bit is the red line, but again, you can look at the red line two ways, both positive and negative. So let's look at it in a positive sense today. Since 2012, we've turned the corner. There's a real problem, I think, with recruiting Aboriginal and Torres Strait Islander medical students, but not graduating them. So there's this about 50% attrition rate. There still is an attrition rate, and we need to work out what that is, but and the causes behind it. But the red line turns up, and it's a lag, an appropriate lag. Not quite an appropriate lag, but it's a lag from the recruitment, and so we hope to see that line continue to grow. But why is it that in 2003 there were only 18 Aboriginal students entering medical school, with lots of medical schools all around the country, graduating thousands of medical students every year? I think it's really interesting to take an international perspective, and these photos and the next few slides are taken from Professor Ian Anderson's Dean's lecture in 2008, where he started to talk about the knowledge economy and Aboriginal health development. And in 1866, Dr. Oron Iateka graduated from the University of Toronto in Canada, a North American Indian. Apparently he was a bit of a rogue, but he graduated from Toronto. In 1889, Susan LaFlèche-Picotte graduated from the Women's Medical College of Pennsylvania, and Sir Maui Pomare in 1899 from Chicago College, a Maori who had gone to the States, and Te Rangi Hiroa in 1904 from the University of Otago. And there's places named after most of these people across medical schools now. It took Australia until 1984 for now Professor Helen Milroy, who serves on the Royal Commission, to graduate from the University of Western Australia. So 80 years behind from Otago, and if we just jump back a few slides, 120 years nearly from North America. So Aboriginal people's engagement, if you like, in the health professions and the knowledge economy has been held back, and we haven't been participants for a whole range of reasons. So there's some catch up to do. Thinking about that, and because the University of Melbourne hosts the Leaders in Indigenous Medical Education project, which I also lead, which has a focus on curriculum development for medicine and strategies for student recruitment and graduation, I want to talk a little bit about the University of Melbourne's Reconciliation Action Plan experience, with the stories in the back of our heads about what's happened in medicine with very low starts and now accelerating some graduations for Aboriginal and Torres Strait Islander doctors. In 2008, the Vice-Chancellor apologised to Aboriginal Australia for the role that the University of Melbourne had played in keeping people out, if you like, of the knowledge economy. 2009, we went through a process of consultation and discussion about what our Reconciliation Action Plan might be, further developed through to the first plan in 2011, and we're currently renegotiating what our RAP 2.0 might look like. A long process which had some issues and challenges which I just want to touch on now. The first one was leadership. When Professor Anderson said to me, we're going to do this and we need to decide what it is we want to do, as Aboriginal academics I said, Ian, I'm not sure it's our responsibility. Surely this is the Vice-Chancellor's responsibility or some other leaders, not necessarily Aboriginal people, reconciling with the university. To which he agreed, and pragmatic as ever, basically says get on with it. The leadership comes from where it pragmatically needs to come from in terms of driving the process of the Reconciliation Action Plan and thinking through this notion of partnership, which I'll get to shortly. So I had some of my own reservations about it, but in the end it was initially driven with a high-level leadership from the Vice-Chancellor and his apology through to the Aboriginal leadership saying these are the kind of things we want to pursue. Partnership was the next important thing, particularly internal in the institution, and finding alliances as to people who would work with us and would for the vision, I think, of a better university. So these are some really interesting and good things we might do around reconciliation. And then delegating and noting who was responsible. So as we wrote up our first Reconciliation Action Plan, and as we're currently doing for our second, it was really important that we named the people that were responsible for the particular elements of the plan, and that'll make a little bit more sense shortly. But different from my first challenge around leadership was that the responsibility wasn't just the responsibility of the Aboriginal people in the university. It became a shared responsibility, although identified to key leaders with delegated authority. We needed to think through the issues of implementation and resourcing. Some things were going to cost things, other things were a time or a human resource issue, and they needed to be identified so that people's workloads were able to be managed. This is not free, if you like. It takes effort, it takes time, it takes intent. And finally, a focus. What we're going to start with, how could we show that this was going to be of benefit for the university, for the individuals within it, both Aboriginal and other Australians. So they were some of the key issues that emerged as we were going through our first Reconciliation Action Plan. The principles that we've undertaken, and this is a little bit technical, but some of the principles that we've undertaken for Reconciliation Action Plan version 2 is that the things we need to do need to mesh with existing accountability structures. It's no point saying these are the things we're going to do as core business for the institution, and these are the wrap things which are added on. They actually had to be meshed with existing structures. They had to build and extend on the core business activities, and so for the university, that's teaching and learning, research and engagement. There's I think over 100 registered Reconciliation Action Plans with Reconciliation Australia, and each of them actually needs to extend on the core business of the organisation that's put them forward. For us, they need to be integrated through the planning cycle, which I guess as an AGM is an ideal time to start thinking through some of those things. And the last point about the principles is that they needed to enable and empower our own faculties to design and implement strategies that meet the particular needs of the faculty's priorities and goals. The reason that's there is because our university is pretty big with quite a few different faculties, and whilst we have a shared overarching vision, the Faculty of Medicine and Dentistry and Health Sciences would have some slightly different priorities to the Faculty of Law or the Faculty of Arts, for example. So it needs to be localised as well, which is, to repeat, why my role as Associate Dean in the Faculty of Medicine was so important. My institutional role, not me personally. So we think through the action areas, and on the Reconciliation Australia RAP framework, there's the three elements of relationships, respect and opportunities. And for the University of Melbourne, we've unpacked them into 6 different areas: partnership, cultural recognition, and so on. And each of these areas as you look at it, your right-hand side, the 6 areas have much more fleshed out activities and aims and delegated responsibilities and leadership and so on. But that's it in a nutshell, and we've set targets for student recruitment, targets for staff recruitment, and on it goes. But, for example, the cultural recognition, which we put out under respect, there's two, I think, key things that we've worked at so far. One is called Bilibulari's Walk. And it's a walk. Bilibulari was one of the Narangita of the Wurundjeri, and so we've named the walk after him. And it's a walk that takes you around the University of Melbourne Parkville campus, trying to show it through a different lens, to show Aboriginal places of importance in and around what could be seen as a transplanted Oxford or Cambridge setting, particularly around the cloisters, to show that the ancient migration patterns of the eels from the Yarra just down there, up Bouverie Creek, from here up to the university, when it floods, the eels, the short-finned eels, are occasionally still seen up around the top of campus. And Bilibulari's Walk came from an idea. I was in London and I was asked to do the abolition of slavery trail around London, which is a walk, and if any of you have done it, you'll know it's a nice place to work out where you are in London, but a fascinating historical journey as well, taking you to some of the great art galleries and museums as well. So we've established Bilibulari's Walk, and the possum skin cloak, that was an initiative that on the occasion of the 150th anniversary of the Melbourne Medical School a couple of years ago, we had the cloak gifted on behalf of the Wurundjeri to the university, and it is now used in high ceremonial occasion, graduations and orations and so on, and has now become embedded as part of university's core business in terms of just how we do things. And the cloak's quite a beautiful cloak, in fact, although as an aside, to have it made, we actually had to get the pelts from New Zealand because we're not allowed to use our own possums anymore. But it's, but that's one of the kind of things that were in our reconciliation action plan around cultural recognition. Reading some of the things about Christopher, this next quote came up. I think it was from when he was at the University of Tasmania, and it was said to him, not something that he said. And I thought this was quite apt when thinking about the cultural recognition, because in some ways, whilst they're intensive and they're time-consuming to get right and they're expensive, the possum skin cloak and Bilibulari's Walk are really important. But there's a whole bunch of other things that we need to get done as well. And so thinking quite deeply about employment, student recruitment and completion, and I've changed the language. We used to talk about student recruitment and retention. There's no point in getting students in unless they were going to get out at the other end. And so we want to keep talking about student recruitment and completion or graduation, and removing from Aboriginal people the shackles of the burden of low expectation. It's a quote I stole from Andrew Forrest when he was giving a talk the other week about his, to some people, contentious employment strategy. But this rang a bell, and getting rid of the shackles of the burden of low expectation for Aboriginal people that come into the institution were quite critical. In employment, we've increased our numbers by engaging in partnership with TAFE colleges to say, okay, if we've got early entry administrative positions, we need people that are skilled to do that, and there's the TAFEs that do upskill and graduate Aboriginal people, and so we're doing some partnership work around that so that there's pathways across TAFE to higher ed in terms of employment. Our student numbers are improving, and that also then ties in with the kind of teaching that we do, the kind of research that we do, so that when students come to the university, they don't necessarily feel alienated by the kind of things that we teach. In fact, in New Zealand, there was a study which showed that if you had what they would describe as a culturally safe and inclusive curriculum, the numbers of students that would identify as Māori over the 3 or 4 year nursing program actually increased. So, for us, a collective us, what might be the possibilities of a reconciliation action plan? I think that we can share lessons and strategies across minoritized groups. How we work in Aboriginal Australia, I think, as a minoritized group, has some resonance and some lessons to teach, but also to learn from other groups. Back to Christopher's language, to challenge the oppression, to address the processes of minoritisation. I think for what I understand to be the core work of this group is also to help to listen to the voice of the Aboriginal health consumer and how might that be best done. And I think ultimately then, with listening to the voice and providing advocacy, to contribute to addressing this notion of unequal treatment, so that anybody that ends up going to a healthcare clinic, hospital, or so on, community health centre, will receive the treatment that they need, rather than the treatment that a clinician might implicitly or not expressly think that they should be giving to a person that might be a bit different from them. So I think, going back to escaping from the jail, I think you can only understand John Gardner and Tullamarina by understanding both of their stories. And I think one of the challenges of developing and implementing a really effective reconciliation action plan for any organisation is about understanding an Aboriginal story. Tullamarina was hungry, he had a family to feed, and I'm not sure what he would have understood to be these settlers, for want of a better word, on his country growing potatoes, which he probably hadn't necessarily had those particular varieties before. And yet to understand also John Gardner, who was himself in a way trying to establish a new life and a new horizon for his family. So an escape from the first jail picture, I think, provides us with a way to think both about where we are in Melbourne, but also about thinking through reconciliation as understanding two sides of any one story. I think, in conclusion, for me, a reconciliation action plan is about the relationship between an organisation and its constituents, in particular its Aboriginal constituents, and in this context the healthcare system. So, thank you, Tony.
Thank you, Shaun. As Shaun indicated, he's happy to take questions and have a more detailed discussion. If people have got particular issues they want to raise, any questions, please start. Joe.
Oh, hi Shaun, and thank you. That was wonderful.
Thank you, Joe.
I just wondered if you wanted to elaborate a bit more on your earlier slide showing the disparity or the difference with access to PBS of Aboriginal and non-Aboriginal Australians, and what some of the things you think are behind that.
I don't have the exact data at the fore of my mind, but I know that some of the highest rates of use, if you like, of I've lost my words, Medicare free, what's the bulk billing, but linking that with the PBS is around some of the very wealthy inner suburbs of Sydney, Bayside suburbs. That's not a comment on those people at all, but it's a comment on how different people use the healthcare system for different reasons. I think there might be a whole range of reasons to understand that huge difference in the pharmaceutical benefit scheme, but it's significant. The government have made some links with Aboriginal healthcare, community-controlled healthcare organisations around the way that they are able to distribute pharmaceuticals. And I don't think we can talk about, to any great extent, remote and rural. Most Aboriginal people live in Sydney, Brisbane and so on. There's a whole bunch of work that's being done in Brisbane for the Institute for Urban Indigenous Health. And what they've done in the last couple of years is to kind of rethink the way that as a community-controlled health organisation they deliver care to the community in southeast Queensland. And you saw the increase in the graph of medical students. That's nothing compared to their increased graph of occasions of service to the Aboriginal community in and around urban Brisbane and southeast Queensland. So if you think through, I think, access a little bit and that relationship with the PBS, I think that might help explain it a little bit, but it's certainly very stark.
Just Joe's question
I think yes is the short answer. Can I give 2 examples of medical schools that have done something in this space? One is in New South Wales, I think Wollongong, but I might be wrong. The other's in Hawaii at John Burns School of Medicine. Both of them, and there's others around the country, but I know them, have developed Indigenous bush medicine gardens to help train their students, medical students, to understand the utility or the use of traditional medicine and so on. On a slightly different level, I think the question could be, it's not my right to tell you how to ask your question, but I can answer it slightly differently to say Aboriginal knowledges could actually be incorporated in a reconciliation action plan. Aboriginal ways of knowing and doing, which include medicine, could be a way to say, well, that's something that we want to recognise and respect as how we might do our core business. One example of that, which is now with the University of Melbourne, the AFL, I'm sure here, is an acknowledgement of country. It's an Aboriginal way of knowing. It's a respectful way to say, actually, we know that people were here, and we know that the Wurundjeri were here, and if Auntie Joy was here, she would welcome you all in. So I think there's a kind of a higher level, rather than just the bush medicines or the Aboriginal medicines themselves, is a way to respect and recognise Aboriginal knowledge in protocol, in business. The cloak and the walk, I think, are 2 examples which can seem trivial, but they're changing the way that we do business.
Some of that reconciliation is actually around enriching both sides of the story.
To take the exact opposite of that, as Keating said in his Redfern address, we are all diminished. So I think we can all be enriched. I think that's what reconciliation action plans can do.
Yeah, thanks very much. That was fabulous. How do you feel about increasing the numbers of Aboriginal kids going to school and the link between getting them to stay in primary and secondary school and then perhaps choosing to become an Aboriginal doctor or a health worker? Is that going to make a big difference?
Yep. The pipeline is still broken and really leaky, and we've got to keep the kids in school. And when I was doing some interviews on the radio for the Melbourne Poche Centre, May, June earlier this year, to I think it was the Central Australian Aboriginal Radio, can't remember. But basically my key message, they have a very youthful audience, and my key message could only be, kids, you just have to stay in school. So we're trying to do at a university level, we have some entry pathways, but we're also doing much more work now, and I think there's much work that we can all be doing around how do we keep kids in school, how do we get them to year 12 when all these other opportunities open up, because you haven't got there, it's really hard from there. So I'm not sure I can add much except say, yeah, it's difficult.
Oh, hi, that was really good. I was wanting to go back to your slide on completion, I guess, of Indigenous people going into medical training and then completing.
Yep.
I suppose the first thing is I think you need to sort of move the bottom graph to the left, to the right, so that it's 5 or 6 years after they've started.
Joe, I did that last week. I was trying to be nice. And last week I gave that same presentation to the medical dean. Sorry to cut you off.
No, that's all right.
The title of that talk could have been the 9-year medical program. Because I have drawn doing exactly what you've asked. And 5 years ago, the 5-year entry 5 years ago was 44 students, which meant this year or last year we should have graduated 44, we only graduated 24. So the challenge to the medical deans in that context was, how do we close this gap?
I guess that leads me to a question I was going to ask afterwards. What's the completion rate of the non-Indigenous students?
Oh, high 90s.
High 90s? So when they start medicine, the process is so good that we've chosen the right people and they continue, or they're just afraid to drop out?
Both and all.
So, have you looked at why Aboriginal students are not completing?
Yep, so I think there's a couple of things to keep in mind. We need to do more research on why we have this attrition rate. We need to know if those So if 5 years ago 44 people came in and this year we only graduated 24, we've lost 20, we need to know where those 20 are. Are they still in medical school doing the 9-year program because they keep being asked to repeat? Have they taken other positive life decisions and decided medicine's not for them, they want to go and do something else? Have they failed and dropped out? And if so, whose responsibility is that failure? And then the other question we asked was, okay, are we doing the wrong thing? Not by getting them in, but are we thinking wrongly? Is this cohort of Aboriginal students substantively different, either in their age, their life experience, their previous educational experience from the other 90+% of medical students, that we're not providing quite the right supports? So I've got a kind of a lazy answer to your question, which is we've got some more research to do there, and we don't know where that lost 20 years. We're not quite sure how to close that gap, but we're certainly working on it because it's completely unacceptable, and it sets the student up to fail. It's costly. It's not a good reflection on the medical school, and it stymies the relationship, if you like, between Aboriginal people and the medical profession, which has been a tortured relationship for several hundred years. So we are doing more work on that.
Along the same line of that, I'm really interested in that retention of the medical students, the Indigenous ones. And I know in the past Melbourne has been very good at offering extra support to Koori students, at a Koori unit. When I worked at the Equal Opportunity Commission, I remember that. And as a community psychologist, I've seen overseas too, where they've done extra programs for minority groups like Afro-American to help get them in, like have extra workshops over the summer before the year starts, so they have more opportunity to get up to speed. But also there was a wonderful ABC radio interview in 2010 with University of New South Wales about the Jewish community, the Shalom Institute, offering scholarships up to 25 a year to put Aboriginal students through medical school and provided full accommodation, full support, so that they didn't have all those practical issues. It's so hard because they don't have families with loads of money to support them like other students may have. And that has really helped the retention rate. So I'm wondering if there could be something done in Melbourne, given we have, Jewish community with lots of philanthropists, I know some of them, if that's something could be done.
I think it's absolutely something we should follow. What University of New South Wales have done has been quite outstanding, led by Lisa Jackson-Pulver and her engagement with the community, but also the way they've set up their programs, very, very well supported, as you've already told us, all the accommodation and tutoring and so on. I think that's a great model, and I think that we're looking at ways to do similar things. We need, in Victoria, we have such, going back to the earlier question about school, we've got real problems at the school end that we need to, we're a national university, we get that, we're an international university, so we'll graduate, recruit students from across the country, but we do, I think, have a bit of a disadvantage in terms of, if we're competing, in terms of pathways in. So we do need, and we are working with our advancement team and potential philanthropists around how we provide that pastoral care and support and whatever that might actually cost to ensure people get through. Can I just add very briefly to that one of the visions of the Poche Centre is for the, so I want to just finalise in my head this pipeline. 2011 or 12, around the country, there were about 10 professorial or associate professor positions in health, in faculties of medicine, dentistry and health science around the country, in and around Aboriginal health, that either A, weren't filled or weren't filled by Aboriginal people. And I think this pipeline has to go from primary, secondary school right up to the leadership of the institutions, so that the kids that they're getting through at University of New South Wales, and hopefully we might get through here, see the mentors, the role models and so on, and say, oh, I can do that because he's or she's from my community, and I know the pathway they've been, and I know their family and so on. So I think there's the two ends of that pipeline.
So
Mm. Mm.
Community advisory committees, generally. And if we think about as health consumer organisations, in a sense we deal with through that show and
Mm-hmm.
other kinds of organisations in context of economy.
Mm. Mm.
In a sense, I suppose is, at this time, is it more of the same, or in a sense, should we be starting to look differently?
I think that's a real challenge because lots of Aboriginal people don't use the community-controlled health sector, which is not to discredit VATSHO or NUTSHO that I know that you guys are working with as incredibly valuable organisations and doing great things, but that's a subset of the Aboriginal community that you'll be talking to. So I could get myself into a very deep hole here by going down this path, but a whole bunch of people want to use the Royal Melbourne or the Royal Children's or whatever. So I think the institutional engagement with the peak bodies is critically important. So NUTSHO and VATSHO in a Victorian context and so on do provide a voice, but it's not the only voice. I guess the example is, sorry to go back to what I know, but the students that you hear at university are a particular kind of student, and particularly our international students, taking it out of an Aboriginal context, we only hear from a certain few of them, and there's lots that just get on with their business who I'm sure we could do better work with and provide a better opportunity for and a better experience, but they don't engage in the institutional student rep bodies and that kind of thing. And I think you could probably say the same about all peak bodies, but in the question that you asked, I reckon there's the two avenues really. Is the peak body avenue providing the engagement that you need? Are they already too busy anyway? But are there other opportunities for communities, individuals in the community to engage? So it's a split answer, but I think there's the diversity of Aboriginal communities is such that lots of people are under pressure with full workloads, particularly the peak bodies. But the right kind of invitation can be taken up by other people as well. But they're not necessarily representatives of a wide group of people. It's hard.
I confirm what you're saying, Shaun, from my own research I'm doing at the moment, working with Medicare locals around Indigenous health, and you're quite right, a lot of Indigenous people don't choose to use the Aboriginal medical services because of a whole range of factors, some including privacy, and they just don't want everyone knowing their business, and so it's really diverse. Yeah. Okay, take one more question.
Excellent.
I'm sure you agree that that presentation was of the same high calibre that we've come to expect, if you like, in relation to celebrating the legacy left by Dr. Christopher Newell. And I personally got a lot out of it, Shaun, because I do some work in this space and I found that very interesting. CHF is also in the process of preparing a reconciliation action plan, and there's some really good indicators for us in terms of us going forward and finishing that off. And I'd like to thank you on behalf of CHF and a small gift token of appreciation. Thank you very much. Thank you. And Bishop Newell has asked if he could just say a few words before we finish off in this section.
It's a pity we didn't have some of the people who run the hotel, if that's what it is. It's a very unfriendly place for people who are daunted by looking at some stairs and then having to go and find that you can't actually get into the lift and operate it. You've got to get somebody to come and work it for you. But that's just by the way. May I express, say how Merle and I are honoured to be present and most grateful to the continuation of the Christopher Newell Memorial Lecture. And today's lecturer has paid a great tribute to Christopher in the work that he is now forwarding and is so vital in this country. So Kerry, thanks to Kerry Hollis for her letting us know exactly what's happening and where it's happening, and you got even closer to Hobart this time, so that's, that suited us very well. Thank you, Mr. Chairman, for your kind welcome to us also, and to Professor Ewen for his words this morning. In today's paper, we noticed in Melbourne the death notice for Professor Tonti Filippini, a philosopher and an ethicist with whom Christopher had sometimes agreed and sometimes disagreed, as it's very important in these areas that there is that kind of cross-fertilisation, if you like, challenge by one person's thinking and by another. But Merle and I were especially impressed by the tribute in that death notice this morning, which spoke of the professor's faith, intellect and wisdom. Now, I think Christopher had a deal of faith. There's no doubt about his intellect. I'm not so sure about his wisdom, but that's the prejudice of a father. I think he was wise on many occasions. But then came these interesting faith, intellect and wisdom, and it then said, illuminated by suffering and love. And I think that's not only true of Professor Filippini, but also of Christopher. He had a tremendous faith and trust in God, generated, I think, more by the example of his mother than by me in many ways, because Merle has a particular way of emphasising the positive and a determination, I better be careful how I say this, a determination not to be put off always by the medical profession who, when they're out of depth, say you better go to a psychologist or a psychiatrist. Merle, on so many, many occasions, was right and eventually found doctors, medicos, who agreed. Faith, intellect, wisdom, illuminated by suffering and love. Yes, Christopher suffered, but he was loved, he loved God, and he was loved by his parents and by his two brothers who are far away from us, one in Canada and one in the United States. Thank you for having us. We go home lifted up, refreshed, and giving thanks to God for the continuing work of the Consumer Health Forum. Thank you.
Thank you very much, Bishop, and thanks again to Shaun. That's the end of our guest lecture, and we now break for afternoon tea. Please stay and join us for afternoon tea. And then at 3 p.m. sharp, for those of us who are members of this august organisation, we will conduct our annual general meeting. Thank you again.